So let's go to the second speaker, and Dr. Saurabh, who is Saurabh Galodha, who is present in Alina Institute, working as a GI surgeon. Dr. Saurabh, he's going to talk about differential diagnosis. Means in brackets, sir has written that how to different how TB can look like. So, Dr. Saurabh, can you please start your presentation and share your screen, please? Thank you.
Good evening, sir.
Show some information about our various activities. So all those who are watching live and who will be watching the video later, this is how you can join Jaipur Surgical Tutorial. Please send a WhatsApp message to my colleague, Dr. Anand Nagar, at this number. And as I said, we conduct a session every Saturday, 9 to 10 a.m. India time. For the masterclass, again, you have to send a message. In fact, if you become a member of JST, you will receive information about the masterclasses automatically. These are done last Thursday and Friday of every month, 7 to 9 p.m. And this is the Friday afternoon session, especially for colleagues from Africa, but anybody is and everybody is welcome to join. This is being moderated by Dr. Kailash Kodia, who's again at AIIMS, New Delhi. And for today, those of you who would like to read more about abdominal tuberculosis, please send me a mail at vkkapoor.india@gmail.com. Write TB in the subject of the mail, and I will be sending you soft copies of some chapters on abdominal tuberculosis, which I have written, as I said earlier, with Dr. Ibrar, Dr. Sasmal, and Dr. Galodha, and a few other of my colleagues. And this is the information about Jaipur Surgical Festival, 6 to 8 December, complications in surgery. That's the website for registration.
Good evening, sir. Myself, Dr. Mohit, sir. I need to say something, sir, regarding diagnosis.
Yes.
Sir, good evening. First of all, good evening to all. Sir, in maximum patients, what we have seen, if we are not able to make the diagnosis just on the basis of the biopsy or on the basis of the any histological, we don't have any histological evidence. So do some non-invasive thing first, sir. Sir, go for USG neck, USG axilla, and USG inguinal region, sir, to find out any lymph node involvement, sir. Then do, if lymph nodes are there, do FNAC or excisional biopsy first. Second thing, go for ophthalmological evaluation for choroid tubercle, sir. Because if choroid tubercle is there, this is the definitive diagnosis of dissemination of the tuberculosis, sir. So USG neck, axilla, inguinal region, along with USG abdomen, ophthalmic evaluation for choroid tubercle, Montoux test. I'm not saying in India it's a definitive diagnosis, but it gives some evidence, sir, regarding Montoux test. So before going for another surgery or another invasive procedure, go for these non-invasive and the semi-invasive procedure. Then we will proceed for the another invasive procedures.
I think very important tips which Dr. Mohit has given here. Yes, Saurabh, are you able to share now? Dr. Mohit is my colleague in pulmonary medicine at my institution. He will be joining us as a panelist tomorrow to talk to us about anti-tubercular treatment. But very important point which he made, that in addition to clinical examination and ultrasound evaluation of all the nodes, and if any nodes are seen, then targeting them, and examination of the choroid plexus by ophthalmic examination.
Yes, I think it should be visible.
Yes. Now we can see. Please start. Yeah.
So the topic given to me was, good evening, everyone. I'm Dr. Saurabh from Department of GI Surgery and Liver Transplant in AIIMS New Delhi. And the topic given to me was, what can abdominal tuberculosis look like? Which is like, what are the differentials of an abdominal tuberculosis if we see the different types of abdominal tuberculosis that are there? So the different types or the different involvements in the abdominal tuberculosis can be lymph nodal involvement, gastrointestinal system involvement, solid organ involvement, and the peritoneal involvement. These are the basic involvement in abdominal tuberculosis. So if we see one by one, we will try to see the differentials in each one of them. First one is the tuberculous lymphadenitis. That is the commonest presentation of abdominal tuberculosis. The symptoms usually depend on the site of involvement that is there, and the commonest being the mesenteric lymph node. So we can usually see something like a conglomerate mass of mesenteric lymph nodes, which can lead to abdominal pain and sometimes mass-like formation.
Dr. Saurabh, move to presentation mode. Presentation mode, no? Yeah, slide. Yes.
I guess better, sir. Sorry. So the differential would be obviously the most common differential usually of abdominal mass would be abdominal malignancy, which can be a non-seminomatous germ cell tumor. A pancreatic cancer can present with the retroperitoneal lymphadenopathy. They can be lymphomas, then they can be metastasis. Then fungal infections like Candida and aspergillosis, and sometimes even celiac disease can present as a tuberculous lymphadenitis. Then, if we go into a gastrointestinal tuberculosis, it's usually rare, but it has got three different morphological types. One is the ulcerative one, the second is the ulcero-hypertrophic, and third is the hypertrophic one. All have almost similar presentations, which can present like an obstruction of a perforation, bleeding, or a fistula. And so, in gastrointestinal tuberculosis, I've actually taken each organ separately. So initially, if we start from above, initially the first one would be esophageal tuberculosis, which is usually very rare and can present with an ulceration or a nodular thickening or a stricture. This could be due to the lymph nodal involvement, which is around the esophagus, which can lead to matting and then causing an external compression, or there could be a nodular thickening in the esophagus itself. The patient usually presents with dysphagia and retrosternal pain, as we can see in the image. There is a large mass in the mid thoracic part of the esophagus, which is causing luminal narrowing. And later on, you can see there are multiple paraesophageal lymph nodes. And the differential to this would be a malignancy. An esophageal malignancy will actually present with similar symptoms and similar presentation also. Then coming on to gastric tuberculosis, which is to the tune of 0.4 to 2%, mostly involves antrum and body region of the stomach, and can lead to an ulceration or a stricture formation, which eventually leads to symptoms like, if it is an ulceration, can lead to bleeding. If there is a stricture or stenosis of pylorus, then it can lead to gastric outlet obstruction. And sometimes there can be a fistula. So what are the differentials? In case of a benign disease, the most common disease that we usually used to encounter and which has actually reduced of late is the peptic ulcer disease and in its complications. Then there is rarely Crohn's disease. Patients can have syphilis and sarcoidosis can present with strictures. Then in malignancy, it can be a gastric adenocarcinoma, which can present like a nodular mass. It can be a cyst or a gastric lymphoma. And sometimes even a pancreatic metastasis can lead to a gastric thickening or stenosis or a stricture formation leading to gastric outlet obstruction. Then coming to duodenal tuberculosis, it most likely due to the contiguous involvement by the lymph nodes around it, or sometimes an intrinsic, very rarely intrinsic hypertrophic change can be there. If there is an ulceration, it can lead to a bleed and also a fistula with the adjacent structures. So what are the differentials? Usually the patient with duodenal tuberculosis or a patient with tuberculosis per se is asthenic, thin, and can present with duodenal obstruction or duodenal outlet obstruction, which can be similar to like an SMA syndrome. Obviously, they can be in D1, there can be sequelae of a peptic ulcer disease. It can be Crohn's disease rarely, and malignancies like lymphoma or a duodenal and a pancreatic carcinoma or the periampullary region carcinoma. Then coming to the intestinal tuberculosis, this I have taken in total because usually the commonest involvement is an ileocecal involvement, and rarely an isolated involvement can be there in jejunum or ileum, but the most common is actually an ileocecal involvement, which can present with pain abdomen, obstruction, perforation, or fistula formation. And the most common presentation, most common differential for this will be a Crohn's disease, which is actually, since the very basic teaching has been that the most common differential of a tuberculosis, intestinal tuberculosis, is Crohn's disease. Although it is very rare, it is usually rare in our subcontinent, but still it is fairly common as far as tertiary care centers are concerned. Then it can be an amoebiasis like amoebic ileitis or a colitis, in salmonella or Yersinia infection, and obviously malignancy like an adenocarcinoma or lymphoma, usually presenting like similar. Like there can be a coning of the cecum with proximal dilatation. There will be multiple lymph nodes which could be present, and this could be differentiating features from a malignancy in case of intestinal tuberculosis. Then coming on to solid organ involvement, then first is the hepatosplenic tuberculosis, which can usually occur due to a hematogenous dissemination. It can be of two forms. One is a micronodular, which is much more common to the tune of up to 80%, while macronodular is usually up to 20% patients. Usually have non-specific symptoms, can have fever, can have symptoms like an abscess. And rarely the gallbladder can be, very, very rarely gallbladder can be involved, but there are case reports of gallbladder tuberculosis also. Although xanthogranulomatous cholecystitis can be said to be atypical, but it's not exactly a gallbladder tuberculosis. And the micronodular can have differentials in the form of a cholangular abscess. Suppose a patient has a cholangitis and then develop cholangular abscess, so multiple small abscesses can be there. It can be other differential will be a lymphoma, obviously metastasis from a primary disease, and then sarcoidosis and fungal infections like histoplasmosis can also be a differential for a tuberculosis. And these can present with multiple abscesses, which can be seen in both liver as well as, if you can see, there are multiple in spleen as well. Then macronodular, usually a large abscess or a large mass can be there in the liver, or multiple conglomerate masses will be seen, which actually points to the differential of a tuberculosis in this kind of a patient. And the differential for such a kind of hepatosplenic tuberculosis will be a pyogenic abscess or a metastasis or even a primary hepatic malignancy. And rarely a gallbladder cancer can also present very similar to such a large mass. Such a large mass is present in relation to the gallbladder. A differential of a gallbladder malignancy has to be entertained and accordingly investigated. And coming on to pancreatic tuberculosis, which is usually a very, very, very rare, but there are small case series and case reports for this. Most of about up to 80%, the involvement is in the head region of the pancreas and can present like a head mass. And there will be retroperitoneal lymphadenopathy associated with it. But the differential for these could be carcinoma. Also, most of these head masses can have cystic component to it. So sometimes the other differential which is entertained is a cystic neoplasm of the pancreas. So then we have to differentiate between these two, and because a medical management of a tuberculosis can lead to resolution, on the other hand, carcinoma or a cystic neoplasm will require surgery. And coming on to the very another aspect is the peritoneal tuberculosis, which is actually the second most common presentation of abdominal tuberculosis. This could be most commonly hematogenous and sometimes due to the contiguous spread from the adjacent organs. There are three types, most commonly the wet or the ascitic type, and the second is the dry type, and third is the fibrotic type. The dry type is the least common up to only 10% patients, while ascitic type can be seen in 60 to 65% patients. So what are the differential for peritoneal tuberculosis? So the differentials for peritoneal tuberculosis can be cirrhosis, anything which leads to ascites, diseases like chronic renal or cardiac failure. Then these multiple miliary tubercles that can be seen can actually be has to be differentiated from a peritoneal carcinomatosis or an ovarian carcinoma or a primary mesothelioma. So these are the various differentials of various diseases that we have to keep in mind when we are considering the differentials of abdominal tuberculosis as far as the organs are concerned. And the organ that is involved, we have to take into consideration as well as the presentation and decide as to how we have to evaluate these patients. You can see in this image also there is an omental taking with some enhancement. In case of this, we can.
Minimum. And any other people, please mute yourself. There are some sound is coming. Sorry, Saurabh, just a minute. Please mute yourself, other people. There somebody is talking loudly and it is disturbing us. Yes, Saurabh, carry on, please.
So as I had described in the previous, this is the wet type. As you can see, there is ascites where there is clumping of the intestinal loops in the center of the abdomen. Similarly, here we can see that there is a transition point and there is a proximal dilatation of the bowel with some amount of loculated ascites. So this is a case of a cocoon or a dry type of abdominal tuberculosis. In this case, where we have multiple loculated omental cake, we can see that there is an omental caking and then there are multiple enhancing nodules inside the omentum. So this is also one of the features of the mental dry type of abdominal tuberculosis, peritoneal tuberculosis, and we can see multiple miliary tubercles, which we can actually see on laparoscopy and then biopsy and send for a frozen section. And if it is not malignancy, then obviously we can consider that this is a tuberculosis, although we have to consider the clinical presentation as well as the patient's presentation to us as one of the factors also. And we have to rule out malignancy before we label the patient as a tuberculosis. So these are the various differentials which we can see in abdominal tuberculosis. I hope I have covered most of the differentials as far as abdominal tuberculosis is concerned. Thank you.
Saurabh, thank you.